Hello everyone and welcome to our webinar this evening on unexplained infertility. We're joined this evening by Ephia Yasmin. Ephia is a consultant in reproductive medicine at UCLH and CRGH, and it's really lovely to have Ephia with us. I wanted to let you know that we're going to be recording this webinar and it'll be available through the webinars page on our website in the next few days. Thank you to everyone who sent in questions in advance. If you want to ask a question during the webinar, just put it in the Q&A box and we'll get through as many as we can. And just to reassure you, if you've logged in with your real name, we won't read out any names. Everything will be completely anonymous, so don't worry about that. Just before we start, I wanted to say that, as you know, we're a charity and everything we offer is free. But if you do feel you'd like to make a donation to help us to be able to continue to offer webinars like this, you can do it really simply by texting now. So you just text 70085 and then put in FNUK and however much you wanted to donate. So if you wanted to donate £5, you could just text 70085 and then put in FNUK 5 or FNUK 10 if you wanted to donate £10. Anyway, thank you in advance to anyone who is able to do that. But now we'll get on to our questions for Ephia. Ephia, I wanted to start by asking, unexplained infertility is one of those slightly frustrating things, isn't it? I mean, how common is it for someone to be diagnosed with unexplained infertility?
So what we need to remember is the way in which we investigate has evolved through the years. I'll give you a simple example, and that is ultrasound. So let's say 25 years ago, the ultrasound machines had not great resolution. The ultrasound machines now have brilliant resolution, and therefore our visibility is really enhanced. And therefore, with the right training and a good machine, we can evaluate the pelvis much more, okay? So I just wanted to put that in because this term unexplained was coined, I don't remember exactly when, but has been going on a very long time. And what is the incidence? What it essentially means is that by doing a certain number and a reasonable number of tests, a definite cause of infertility hasn't been detected. One thing I want to make very clear, there are causes of infertility and there are very few. And most other conditions are associations. What that means is, sometimes when we look at and when we investigate, we get certain findings. And then we correlate that with the population we are studying, and we may find that, we find more of this condition in this population. That doesn't immediately mean that that is a cause for that condition, or in this case, infertility. Let's take an example, endometriosis. There are women with endometriosis who will conceive naturally. There are women with endometriosis who may struggle to conceive or have conception delay. But we know that we find endometriosis more often in the population, sort of the population with conception delay. So we have got this correlation, but we equally know that it's not an absolute cause. So the absolute causes are essentially four, if you would consider, not having a uterus, but essentially not having eggs or enough eggs, not having sperm or enough sperm, and not having functional fallopian tubes. So those are the absolute conditions. The rest are relative. And because I work with in women or with women who are born without a uterus, so of course the other one is if you're born without a uterus, that would be an absolute cause. The rest is unexplained or undiagnosed with the means that we have used to diagnose. So how common is it? About a third, so about 30% is usually. So what we mean is that by doing the investigations, we haven't found a male factor or any problems with the fallopian tube or the ovaries. The rest, you might find fibroids, endometriosis. Of course, then we would still not say this is unexplained. So again, if we find a normal pelvis, and therefore regular cycles, therefore confirmation of ovulation, and then we would come to the conclusion of unexplained. I know it can be a mouthful. Unexplained does give these connotations that you've just mentioned of not knowing, just being in the dark. It's not the case. What you have done is you've eliminated the usual causes, okay? And we have to appreciate the fact that we do not know everything there is to know about fertility. So yes, it doesn't necessarily have to have this connotation, this negative connotation, although infertility is, of course, a diagnosis nobody wishes for. But what I'm saying is that it shouldn't bring about frustration. But I'm sure there will be other questions that will lead me to elaborate more on this.
Is it sometimes a matter, which I think people often assume, of a doctor not having done enough tests? People sometimes think, oh, I'll go and find another clinic where they'll do some more tests and they'll find out what's actually causing this. Is that sometimes the case?
The straightforward answer is no. Anybody, of course, it depends on what tests are being performed. Now, if I do not perform basic semen analysis, or I do not or not, very importantly, of course, before any investigations, I would like to talk about the history. In fact, it's history. It's a history taking that will reveal a lot about. So taking a very good history. So if I took a suboptimal history, more than doing fewer investigations, yes, then I wouldn't diagnose. You're absolutely right. I might miss subtle things, such as, someone whose history may have some suggestion that although the fallopian tubes are open, they may not be very anatomical. So they have had, say, a lot of surgical history. Multiple surgeries have been carried out. Okay, so just to give you a very kind of rough example there. So history, number one. Investigation, it's not about the numbers. Of course, we have to do the basic investigation, which means those ones that are absolutely evidence-based. That's what I mean. And it has to be about quality. I mentioned ultrasound scan. Most of what we do will come from a simple semen analysis and definitely the history. Not even loss and loss of blood tests, but a very good pelvic ultrasound scan gives us a wealth of information. What is the ovarian reserve like? Because we can count the number of follicles. Are they all anatomical? Are they, or is there any evidence of adhesions? How will we know if the organs are not moving? There are ways. So with proper training, we can do all of that. There's suggestion of adhesions. So the tube and ovary and their anatomical relationship may be disrupted. Okay, is there adenomyosis? Now, adenomyosis is a condition where some of the cells that are very similar to the cells that line the womb, the endometrium, may be in the myometrium, which is the muscle part of the womb, often causes very painful and heavy periods. Now, the definition of adenomyosis is still a little bit controversial, and not often people kind of look for it. So again, by doing a good scan, we can detect all these causes or all these features even, and all of them may contribute to conception delay, not absolute infertility, conception delay. So I would first say a good history and the quality of the investigations rather than the quantity. So there is a place for additional investigations, but it really depends on the person's individual history. It doesn't mean throwing the kitchen sink of investigations to look at immunology, NK cells, and all the rest of it.
Could I just pick up on the point that you made about history? I mean, would someone know if they went to see their specialist and they didn't ask them the right questions? Are you likely to know yourself because you've had problems in your history, or could it be something that you wouldn't know? Would you be aware, is what I'm saying, I suppose?
Very good question. I think yes. So this answer is yes. When you have any interaction, it has to flow, okay? Sort of. And people can gauge as to the amount of probing that is taking place. So a fertility discussion cannot end in 10 minutes. If it's only been 10 minutes, I mean, I would be a bit concerned. Yes, somebody, may be able to get as much in a shorter period of time, but time is one thing. And one should never hesitate to volunteer information, because sometimes people think, oh, I don't think this is related because this has to do with, it can be a skin condition or what someone may assume to be unrelated, but there is nothing that can be unrelated. Anything and everything may give a clue. So I would say definitely volunteer information. So if somebody hasn't asked about what medication are you on, I mean, that's obviously a major thing because, certain medications can interfere with ovulation. Even painkillers, if somebody is taking ibuprofen regularly, in the luteal phase, we know, we don't give non-steroidal anti-inflammatory drugs in that period because it causes the corpus luteum. That means after ovulation, the structure that produces hormones to sustain pregnancy, which is the corpus luteum, it can regress quickly. So it's, the subtle things. So a very deeply probing history is important. And I cannot but emphasize sexual history in the sense the frequency of intercourse. Do they even live in the sort of same space? Or with work, they may be traveling all the time. They may be in different time zones that can affect, So history is so important. And not only to obviously try and find or have a differential diagnosis, and that history should inform the type of investigations. So I was talking about immunology. If, on the other hand, someone says, I've got a strong family history, got rheumatoid arthritis, I've been diagnosed with thyroiditis, I've got a thyroid problem, I've also got this joint pain, you kind of think, yes, I have to delve more into immunology. So it's history that should inform our investigations.
Is unexplained infertility more common in older women than in younger ones?
No, the answer is no, in the sense, if there is conception delay or infertility in someone who is older in the reproductive sense. So what do I mean? Because someone who's 37, 38, 39 is a young person. But in the reproductive sense, the female is older. If 38, 39 doesn't mean they're infertile. It just means that every time they try, they have a lower possibility of conception than someone who's in their mid-20s or early 30s, okay? But if there is conception delay, then the same investigations ought to be done, but that conception delay cannot be attributed to an unexplained cause. It's very likely to be age-related. But we've got to be very cautious here because someone being slightly older doesn't automatically mean they are infertile. But yes, the fecundity, which is the ability to conceive every time they try, is going to be diminished. Equally, if I may just add on another point to your question, some people do their ovarian reserve test and it's found to be low. And then they are told, oh, this is the reason you are not conceiving. In a young person, a low AMH is not a cause of infertility. All it is measuring is ovarian reserve. It's not telling people how fertile or infertile they are. How fertile or infertile will depend on lots of factors. Age is, of course, a very significant factor, both for women and men. Yes, the effect of conception delay or effect on fertility and therefore, a conception and a continuation of pregnancy. Yes, that effect in terms of male is not as pronounced. That means those effects occur a bit later in case of sperm. But there is now enough evidence to show, the effect of paternal age as well.
What about treatment outcomes? Does unexplained infertility make a difference when you're looking at how likely you are to be successful with treatment?
It does. It does. When everything is normal, and this is again a message I want to send, is, yes, it is frustrating not having a cause. So, the natural tendency is, can I do more tests? I want answers. No, by doing tests, if normality is detected, if abnormality is excluded and normality is, confirmed by these tests, that's actually a good sign. And there have been enough studies looking at the long-term outcome in couples and individuals who have not had a cause detected for their subfertility. And 80% of them have had children, live birth. Yes, sometimes with assistance. One of the most recently published studies, it's called the FAST trial, FASTT. It shows that about 36% conceived with IVF, just under 6% with IUI, and the others conceived naturally, but eventually 80% of them had pregnancies.
I think one of the things with unexplained infertility is that people often try to look for a cause that they might find themselves. I mean, do you think that stress, people often blame stress, do you think that could be a factor in unexplained infertility?
Stress is not a direct cause of infertility. That we can say with certainty, because often we fertility people, we talk about, there is no absolute evidence or solid evidence, but we can definitely say stress doesn't cause infertility. But can stress sort of lead to certain factors that will make the opportunities for conception lower? For example, stress may mean not having sex often enough. Stress may, sometimes extreme levels of stress can affect, of course, hormones. For example, we know that sometimes, it stops people from ovulating, but it has to be quite extreme. But stress in itself is not a cause of infertility. However, stress, we know, is very, very bad for health. So when someone's trying to conceive, and in any other circumstances, but of course, because we are talking about infertility, it's very important that they are in the best possible health. And alleviation of stress is very much a part of that. Okay, so the stress relief is not to say, you are stressed, that's why you're not conceiving. Absolutely not the case.
Another thing I think people sometimes think is that if they go to a private clinic where they will do more tests, they might be more likely to find something and more likely to be able to have a successful outcome. And I think what you said about unexplained infertility and outcomes suggests maybe that's not the case. But do you think that that is something that might be a good idea, to have more private tests done?
No. It's not, as I said before, it is not about the quantity, it's about the quality. And the quality of tests will vary, again, based on the training and sometimes the culture of a place, etc. There'll be so many factors. So it is not about NHS, private, etc. I will say one thing though, time is important. Being seen in a timely fashion. For example, if and this is what we, again, Fertility Network UK and British Fertility Society, we want people to be referred on time. Because yes, in the NHS, if there are delays in even starting to, investigate, and we know that the passage of time does contribute, that can have an adverse effect. But in itself, it doesn't kind of work this way, that more tests in a private sector automatically means better outcomes.
Another thing people sometimes raise is around having the right mindset. And I think sometimes there's an idea that if you go into fertility treatment with the wrong mindset, that might make a difference. I mean, how would you answer people who get very concerned about that? Because there are a lot of people out there sort of suggesting that you need the right mindset and that might make all the difference when it's unexplained.
No, for the fertility journey is not a game of tennis or some sport that you have to go with the right mindset. Again, I will just come back. No, it's nothing we're doing. We all have, different baseline levels of resilience, anxiety, okay, how we cope with challenges. We are all different. And again, I would like to say that if people have that. And if they have that insight, that they have anxiety, they have stress, that needs to be obviously conveyed to the physician, because we ought to do everything we can to put measures in place to alleviate that. Often, of course, realistically speaking, we cannot just eliminate it, but it's very important. And I go back to what I was saying earlier about good health, because good mental health, good physical health is important. When I say health, and mental health is not excluded to start any treatment in order to conceive in the best possible health. So yes, help is needed, but of course it is not down to the individual, and it is not the fault of the individual for having negative thoughts and that somehow it's making it more difficult for them to get pregnant. That's not the case.
We've got a question from someone who's asking about having a short luteal phase and having shorter cycle than normal. They say there's a 22 days. I mean, can that be a cause of unexplained infertility?
Well, it wouldn't be unexplained in that case. So because it's not infertility. Very short cycles of could mean one thing, and we need to investigate that. So going back to history is, as I'll take all the history. Very short cycles will, maybe a clue about diminished ovarian reserve. What happens when ovarian reserve is quite diminished is the signals to the brain, to the pituitary gland, will be sent with low estrogen levels, and high levels of FSH will be released. And this will bring on recruitment of follicles very quickly and may lead to, short cycles. So short cycles can be, or irregular cycles can be, one of the features of very early ovulation, and therefore a shorter luteal phase. Short luteal phase is a very controversial topic in itself. Say ovulation is at the right time, but the luteal phase, ovulation was on day 14, and luteal phase was only 7 days. That's a bit unusual, can happen though, and is observed, has been sort of in our kind of discipline as a condition for a very, very long time, but there is no clear answer to that. However, when someone's trying to conceive and we detect maybe low progesterone or a shorter luteal phase, yes, we may initiate treatments such as progesterone to lengthen that part. But as I said, it often comes from the first phase, which is the follicle phase, when the follicle is developing in order to release the egg.
Someone else has asked what tests you would recommend that everyone actually should have. I mean, we've said a lot that we don't need lots of extra ones, but what are the fundamental things that you think everyone should have done?
Yes. After history, okay? Can we all agree a very, very good history and then certain tests? In fact, I think we do more tests than are necessary. So the very important tests are the semen analysis, number one. Number two, a very good pelvic scan. So in the right place. Because yes, we are not doing these pelvic scans just to detect a cyst, because a presence of a cyst in the ovary doesn't mean there is infertility, but it is about all those other subtle features. What, are there any adhesions? Is there any sign of endometriosis? Because contrary to popular belief, a good quality ultrasound can pick up endometriosis. Are there any fibroids? Are there fibroids? Now, fibroids in themselves are not causes of infertility, but if there's a large fibroid encroaching the cavity of the womb, it can act as a foreign body in the womb, right? So it can definitely limit chances of conception. So good ultrasound scan and basic tests for ovarian reserve, which will be in the form of anti-Mullerian hormone and an FSH with or without LH. Again, it depends on history, but other hormone tests. So if there were irregular periods, then there will be other hormone tests, okay? So I'm talking about when everything looks normal. And estradiol, which is an estrogen, because many times estrogen is left out. Then people do day 21 progesterone. In the presence of a regular cycle, day 21 progesterone is not necessary, because regular cycles means they are ovulatory. So the individual is ovulating. And in irregular cycles, the individual is either not ovulating or ovulating inconsistently. We don't need a progesterone there to tell us more. So these are the basic tests, and they can all be done at the GP surgery. Thing that we find there's a lot of variation is, because tests are tests, when it comes to blood tests, they're going to be very similar because they're all in accredited labs. But it's ultrasound scan where we find variation.
Someone's asked a question about having a hysteroscopy or hysteroscopy after failed treatment and some time of trying to conceive. Is that ever recommended?
Hysteroscopy again should be done at the outset, given again with history. So if, of course, in case of regular cycles and say normal semen analysis, yes, we would do a hysteroscopy to establish. So it is a tubal patency test with other tubal patency tests to see if the fallopian tubes are patent or not. So all they are going to reveal, and ultrasound is a good way, and hysteroscopy is a good way because it's enabling you to do the ultrasound and also check fallopian tubes. Okay. So I think the question is whether it has any use after failed treatments, if one hasn't been done before. That's actually a good question in the sense there's been some evidence that the performance of a hysteroscopy with the pressures that are, sort of the uterus and especially the fallopian tubes are subjected to through the contrast, they can perhaps release some very filmy adhesions. So there, again, it's an observation that after hysteroscopy, there are conceptions, but at the same time, it's possibly just a passage of time because, as I was saying, most individuals with no detectable cause of infertility will conceive. So sometimes they conceive after hysteroscopy as well. But yes, it is a fairly low risk procedure, so it wouldn't be amiss, but it depends again on the context of everything else. But if somebody asked me, can I have a hysteroscopy? I've had IVF, I've never had a hysteroscopy. I would say, of course, we can do one.
Someone's asked a question about what you said earlier about 80% of unexplained infertility couples will end up with a baby, and they've asked over what time period that is. Obviously, that's a crucial
question. Yes, it was over, I forgot the exact period of time. I think it was over 5 years. Yes, but actually that brings me to one important sort of fact about time scale. If a couple doesn't conceive through natural means in a year of trying with that particular regularity, having sex 2 to 3 times a week in a year, then that is classed as infertility. At the time, that means investigations should start. But we also know if there are risk factors already present or if women are reproductively older, then these investigations should start earlier. And that's nice guidance as well. And if no abnormality is detected, then you can have expectant management, okay? So how long can have expected management? Another year, certainly. 3 years is often the max, okay? So because if conception hasn't happened in 3 years, the possibility of a natural conception will decline. So therefore, I would say that in 2 years, in the background of an undiagnosed cause, assisted conception is warranted. Okay.
And quick question for you here, which is someone has been told they've got a tilted uterus and they're asking if that can affect fertility. That's a quick answer and a quick answer.
But can I just, there's always a but with us people. So uterus can be tilted forward. Now, again, it tilted, what does it even mean? Uterus can be tilted forward, which we call anteverted. If the bladder is here and it is tilted forward. And in 80% of cases, it'll be tilted forward, but also it might be a bit straight as well, which we call axial, or tilted backwards with the bladder here, which we call retroverted. Retroverted uterus is not a cause of infertility. But as I'm doing the scan, I will see if this is associated with any a restricted mobility of other organs like the ovary, because sometimes, say, with adhesions in the back of the womb may be tilted backwards. Okay, so alone, absolutely not. But if I see that, but anyway, I'm going to be looking for other signs. So also with a backward tilted uterus.
I know, Ephia, that you've got to go, but I did just want to ask you one last question, which was, do you think there are any things that are going on at the moment, any new kind of discoveries, any new exploration and research that might make some of these causes of unexplained infertility actually be explained in the future?
Yeah, of course. We do not know all there is to know, and things take time. So I will start with sperm. I think, because whenever we talk about infertility, it is so heavily centered on the female. So with sperm, we often, we would take a history from the man and do a semen analysis. Then we would apply the WHO criteria, which have just been, re-released. They keep getting, re-released, and about whether this sample of sperm can be classed as fertile, subfertile, or, suboptimal, etc., etc. There are other tests being, looked into, such as DNA, sperm DNA fragmentation, which is kind of a bit older rage at the moment. We don't know everything there is to know about it. But what we do know is there is more to sperm than just some counts and movement, okay? But this is research going on. Then there is more research going on in the uterus itself, because the lining, we get good quality embryos in the context of IVF, everything seems fine, and we are putting embryos back, yet it is not implanting. What is going on? Then in the endometrium, the signals, they are so subtle, they are so complex at a molecular level. So endometrial receptivity. There are already tests such as endometrial receptivity tests that are done if cycles fail. Again, we have gaps in our knowledge, but this will be in evolution, and we are going to find out more about this interaction between the lining and the embryo. Then the muscle of the womb, does adenomyosis play a part? Does it affect how the uterus moves? When you do scan, you will always see what we call peristalsis. There is subtle movement, and this is normal. There has to be movement, including when the sperm is ejaculated into the vagina, the sperm will swim up, and there will be movement of the muscle as well. There is movement within the fallopian tube of propelling the embryo from the fallopian tube into the uterus. So we are looking more into these movements. Are these movements disrupted in certain conditions? Okay, will that lead us to know more about the fertility process? So yes, these are some of the areas of active research. I can have another few minutes.
Okay, that would be great. That would be really useful. Someone's asked a really good question, actually. I think they've said, does unexplained infertility really exist? Surely there's got to be a problem. After 10 years of trying to conceive with unexplained infertility, I struggle to accept that diagnosis.
Unexplained infertility is not a diagnosis. It is what it says. Yes, there's infertility. We are unable to find an exact cause for this. Okay, and I can safely say that if I just sort of have a crystal ball, will we ever find answers to everything? No. There will always be frontiers. Yeah, like look at the success rate. Okay, I'll just give you an example. Look at the success rate of IVF, especially in, again, the reproductively older women. They are getting better. Okay, because we are pushing some frontiers, we are getting marginal gains. That will happen. We will know more, but will we know everything? We will be able to pinpoint causes, because we don't even know why a pregnancy actually occurs in the first place. Why does the uterus, the body, not reject it? Because there's foreign protein. If I were to graft anything else, the body's immediate reaction will be to reject it, but the fetus is not rejected. We haven't found a reason of exactly why that is the case. So also we will not find answers for everything when it comes to fertility. Sorry to say that. I wish I could say, there will come a time where, but it's not going to happen.
Someone's asked, what about the 20% of people who weren't in your 80%? What happens to those people? What's the prognosis for them, do you think?
This is kind of we have to remember that age will play a very significant part in this, okay? Because in those 5 years of assessments, somebody who started their journey 35 will already be 40, or somebody started at 38, he'll be so much older. And we know that after 43, success with any now conception, naturally conceived, assisted conception using own eggs, will decline, and that is biology. You asked about causes. Now, science may find a way of creating new eggs with stem cells. It may happen. That can happen, and that would obviously be like a huge shift. It will be a game changer. But yes, what will happen? So we have to think about routes to parenthood. And here I will take a moment to talk about donation. Sometimes what happens in the sometimes with treatments, we may forget what is it we are trying to achieve. Why say we? Because this is collaborative. It's about a family. It's about extension of the family from 2 to 3, or even from 1 to 2. And there are other means. Okay, so, and when we look at, and Kate, you know this very well, look at the outcomes, and we look at these families who have created families through other means, taking third-party help. Are they any less happy? The answer is absolutely not, right? So time and again. So it's about exploration of other options. But of course, these are deeply personal decisions.
I think we've got quite a nice closing question for you, possibly, Ephia, which is, are we likely to have trouble conceiving every time, or is it possible that having a baby could actually make it easier to get pregnant again if you've got unexplained infertility?
There is no clear answer to this question, but there is definitely better prognosis based on the fact that that couple has proven their fertility. Okay, so fertility, yes, if it's happened once, it can happen again. But we equally find that the first conception was at age 38, and the passage of time is kind of continuing. So it's a difficult one. Again, it could be, say, quite severe endometriosis, which was just treated. Of course, then it wouldn't be totally unexplained. But in a very straightforward sense, if a couple has conceived recently, I say, what are our chances of conceiving again? I would say very good. And if there is time on their hands, they have good ovarian reserve, good sperm, definitely, and they have conceived naturally, then the advice certainly would be to try and give a decent period of time for that to happen again.
Thank you so much, Ephia, and thank you for answering all those questions. You've been absolutely brilliant this evening, and we're really grateful for you to giving up your time. I know that you've got to rush off, but we really are very grateful. Just for everyone else, a reminder that we are your charity. We're here for you, and if you need support or information, you can find our support and information lines on the website. And you can also find details of all of our groups and all of our upcoming webinars. Next week, we've got a really interesting joint webinar with Hana, the Jewish Fertility Support Network, looking at the changes to the rules on storage and consent and what they mean for you. And we'll be joined by Rachel Cutting from the HFEA. So do come and join us for that webinar if you're free. But thank you all so much for joining us, and we hope that some of you will be with us next week. And thank you, Ephia. Thank you.
It's been a pleasure, and good luck to everyone.
Thank you.